Okay. Hi. I am Susan Bockrath, and I'm going to start out by... What happened? Okay. Oh, it's back. Okay. I don't know why it went to sleep. Sorry about that. I just wanted to first clarify that I am the steering committee chair for Health Literacy Nebraska, but that's one of many hats that I wear, and it's actually the hat that I wore that kind of set us up to be able to do some of the work in local public health departments that we're doing. But I do work for the Nebraska Association of Local Health Directors, and for this particular conversation, when we're talking about statewide public health, that is the organization that has really put Nebraska on the map, even though we're still white on Andrew's map. So I'm just going to give you a little bit of a geography lesson, because I know that a lot of you are not from the Midwest, and the Midwest to you is just a bunch of states with the letter I in them. Nebraska does not have an I in it, but we are in the middle and surrounded by lots of I's. We are red in the middle. We are also red politically. We are a big state. We're about half the size of California, 16th out of the 50 states, but we have a lot of room to move because there aren't that many of us there, which creates some challenges when you're talking about public health departments. We have an older population than the national average, just slightly older, about 14% are elderly. And we are very white, but we're probably not as white as you think we are, because we have a lot of, we have a growing Hispanic population, where it's estimated it'll be about a quarter of our population by 2050. And we have sizable refugee communities and former refugee communities, including Omaha being probably the largest population of Sudanese outside of Sudan. So we might not be what you envision when you think of Nebraska if you've never stopped over. And we do have 4 native tribes who call Nebraska home. So I will talk about a little bit about Health Literacy Nebraska and the Outreach Partnership to Improve Health Literacy, which is a project of the Nebraska Association of Local Health Directors. And I know that this is a health literacy conference, but to make myself go faster, I would like to just call the Nebraska Association of Health Directors, Local Health Directors, I like to call them NALD from now on, and have you know that that's what I mean. So Health Literacy Nebraska kind of set NALD up with some of the connections that we were going to need to be able to do the project that we are doing. We started in May 2011, right after the IHA conference, where we did not have a seat we did not have a table at the networking luncheon, and we were very upset about that. So we started. So Michael Valera got Health Literacy Nebraska started in his own way. We started as we started as 4 people at our summit we did in last January. We had 125 people registered to attend. We had a blizzard that got in the way of everybody attending, but we had a really good turnout in spite of that. And from our work in Health Literacy Nebraska, we've got 2 work groups, and one of them is doing training. We're doing Plain Language on the Plains webinar series, and the other piece that we're doing is we're working on getting 3 health literacy items on the BRFSS in Nebraska. As late as June, we thought we were the first state to do this, but it turns out that Kansas is also doing using these 3 items as well. And so I'm excited to sort of talk to Chloe a little bit about how we might be able to use some of that mapping data that you are using to decide if this is a good use of our time and resources going forward. But both of these activities are really about getting health literacy out from being hidden. And so whether the BRFSS items prove to be useful in mapping health literacy, it does put on the map that health literacy is one of the predictors of the negative health outcomes that public health is concerned about. So we're excited about that. So I'm here really to talk about the Outreach Partnership to Improve Health Literacy, and stepping back again to give you a little bit of context. Nebraska has 96 counties. We are served by 21 local health departments. So if you do the math, you see that not every county has a local health department office in its county. many of our local health departments have surface areas larger than many states, including the state of Maryland. We are a decentralized system in the sense that all of our local health departments are standalone agencies. And RV gave us the title of the strength of weak ties, and we really do embody that in the sense that because of our weak ties, we are able as local health departments to do things that the state hasn't quite gotten to the point where they're ready to do things related to health literacy. But we're also in a position to bring them along with us. We have 16 rural health departments who are participating in this particular project. Because it is funded through the Office of Rural Health Policy, our three urban districts are not able to participate with us. But we basically are covering 83 of the 89 counties that are designated rural or frontier in our state. So when you look at our state and the coverage of our project, we basically are everywhere that does not have the little black lines through it. We have gone through various processes to sort of figure out what our focus areas were. We did a survey, we did site visits, we did needs assessment, and we came up with these focus areas for our 3-year project. We're working on written communication and materials and making them more health literate. I think that tends to be when people are new to health literacy, that's where everybody kind of starts, and there's certainly a lot of work to be done there, and there's a lot to be learned about health literacy in the broader sense from the exercise of going through your materials. So that's what our first focus area. We're looking at developing a more functional and user-friendly system of sharing for our local health departments, not just at the director level, but for their staff. When you have small health departments that are serving huge areas, it's pretty isolating, and a lot of our health departments will have, a single person who's working in a certain area, and so there's not a lot of opportunity, on site for colleagues to bounce things off of, and so we're trying to create a space for that. We want to address language access for all audiences using health literate strategies, and language access in rural Nebraska and health literacy are very closely tied together, and we've talked about this a little bit today already, but it's something that we as a project really need to pay attention to, because I think that language access is something that oftentimes local health departments have in rural areas in particular have the least amount of on-site capacity to sort of that they feel confident can deal with it, minute by minute. And so it's something that really weighs heavily on the staff. And so we're trying to address that with this project. And then we're also, as I said, trying to bring the state along, trying to bring our partners along, rural hospitals, other associations, so that we can elevate the profile of health literacy in public health across the state. So far today, we've had 144 local health departments and staff participate in site visits and technical assistance visits. We've had 230 folks took a survey of staff and directors. One of the things I think that's been our biggest success so far has been we've had 77 staff so far participate in health literate writers workshops, and those were all-day events that were held in various locations across our state. People brought their own materials to work on. We talked about health literacy, the big picture of health literacy, but then we really sort of took it down to the level where we were working in real time on materials that they had brought that they were either wanting to review or were in process, and that's been a really well received activity. We sent 8 people to the IHA Health Literacy Conference here in Irvine. We bought health literacy advisor software licenses and got sort of hard copy starter kits of different resources to all of the local health departments so that they would have those resources to use. And then we're working on developing communication infrastructure and collaboration infrastructure. So we've improved the website for NALD. There's still a lot that could be done to make that better, but we've made it more of a resource, or tried to make it more of a resource for our health departments. We've created our own sort of internal listserv to have direct communication with staff and directors and partners if they choose to join it. And then, this keeps advancing on. And we've just purchased GoToWebinar software, which we're using to kind of build on, and this is coming up, web-based collaborative document review. That was something that came out of our writers' workshops. People really wanted that opportunity to continue to work across the state with their partners. All the writers' workshops included staff from various local health departments, so it wasn't just the same people talking to the same people. We were really trying to get them to sort of talk across the health departments, and they really liked that, so we're trying to set up some regular collaboration via GoToMeeting for that. How am I on time? Okay, and we're applying health literacy to the task of addressing language access. We're co-sponsoring a conference highlighting health literacy and cultural competency this summer, and we're working on helping, setting up some resources, better resources to sort of, and some training specifically around helping local health department personnel talk to partners about health literacy and how they would want to be able to pay attention to health literacy in their local clinics and their hospitals and things like that. And then in year 3, all of the health departments are going to be developing their own pilot projects. There's funding in the grant for that, but that it sort of remains to be seen what people come up with. We spent a lot of time thinking about the attributes of health literate organizations because we really wanted to use those. We got our grant basically the same month. We heard about the grant in December, and I think the attributes came out in January. And we were very excited trying to sort of we were excited about them, but we've been wrestling with them, trying to figure out how do we get them to apply to the work that we're doing, especially when a lot of our local health departments do not provide direct clinical services. And so the emphasis on the clinical piece really was hard for us at sometimes. But we did use it as we were trying to frame some of our questions around our needs assessment. And I just wanted to talk quickly about some of the things that we sort of have observed about some of the attributes. First of all, related to leadership and quality improvement, the leadership in local public health across our state, even though they are all sort of independent entities, have really embraced this as something that is going to give them big bang for their buck. And they don't have a lot of bucks. So they're very excited about the bang part. They are making their own, they're trying to come up with ways of connecting health literacy to their own QI work, and they're looking at ways to create policies around health literacy, but at this point we're not running across we have not come across yet the templates for creating those policies that are good fits for the organizations that I'm working with. I'm going to just skip over a lot of this, but prepares the workforce to be health literate and monitors progress. That's basically the heart and soul of what this whole grant is about. So I think we've got this in spades. Obviously, there's the monitoring participation. We're doing great because that's easy. Monitoring improvement, it's going to be a little bit harder for us to sort of figure out how things are improving. But you know, when we look anecdotally at how people are sort of thinking about their own work, comments they make about the changes they need to make to their work, we're seeing a lot of really positive comments. And I think now, while when we did our survey early on, people kind of tended to rate their health departments pretty high in terms of different health literacy constructs that we were trying to look at. In fact, I think now if we went back and did it, they would rate themselves lower, but with the understanding that they're learning how to do it better. So I think that that's all very positive. I'm going to skip that one. We're including the populations served in design and implementation, and we're not doing a good job of that at the local public health level. I think part of that is a result of it's hard, it's time consuming, you need resources for that. The distance is an issue for us, but there's also this fact that we in public health have been working with coalitions for so long that people have kind of decided that their coalition partner who represents a group is the person who they need to talk to about whether this communication is effective. And not that that isn't a good step, but we need to get to the next step where you ask that coalition partner for access to the actual audience that you're trying to reach. And REITs, a lot of them thought 43% thought they were meeting the needs of populations of various literacy skills. I think that number, like I said, would be lower if we were to do our survey again. Using health literacy strategies in interpersonal communication, just like a lot of the research that's been done in more clinical settings, people reported that they used kind of teach-back sort of techniques, but when you got down to sort of asking more specific questions about it, there's not a lot of evidence that they're using it as much as they think they are. So I think that there's room there. And one of the big things with the challenges in public health, and especially in rural areas, with those kinds of interpersonal communication strategies questions, is that in public health we don't always have the luxury of speaking to the person we're talking to in person. And so that checking in with an individual is an option. And so we sort of have been thinking about how do we make usability testing and user testing sort of the teach back of the public health realm. And that's something that we're sort of still thinking about. That's not something we're implementing yet, but that's something that we're looking at. And I think I'll just go ahead and skip through these because in the interest of time. I just wanted to end with, since I'm talking to you all and you're going to write your new IOM report, that's a great idea. Some of the things that we've kind of wondered about or would like to see the attributes help us address would be, again, those limited, we have limited direct healthcare services, and we've already talked about this a little bit, so we would like to see those attributes kind of reflect this idea of all of those different, the assurance issues, or assurance and all the different aspects of public health better. We would like to see us highlight language access. That's something that came up constantly when we were talking to people in the field. And again, it's because people just don't know what to do. And I know that there's a discussion, I've heard discussions about, wanting to keep cultural competency and health literacy separate, wanting to put it together. I argue that we need to put it together, and I argue that for health literacy, sort of at the ground level, that language access piece is really kind of the crux of where we need to start. And I'd love to have input on how usability testing can be a proxy for teach back at the population level, and again, those policy templates and guidelines that are appropriate for local health departments.